Thank you very much. It's really a pleasure to be here to be asked to speak about this topic. All it kind of flatters me. I'm not really an expert in this area. I do have some publications, but mostly with my friend and collaborator Sari Reisanen, who's a really wonderful epidemiologist who's worked using the medical birth register and the hospital discharge register in Finland to establish much of what we know about the epidemiology of OASIS. And I'm presenting a lot of her work this afternoon. I work here at St Mary's in West London. This is the building where Alexander Fleming discovered penicillin. We still do a lot of work on infectious disease epidemiology. These are the aims of the talk. A little louder? The aims of the talk are to review the definitions for perineal trauma, which you may all be familiar with, look at trends and incidence of OASIS around the world, and then in some detail, my favourite part of the talk is to look at the risk factors for OASIS, which really underpin how we should manage women after OASIS. So first, the definitions. I think probably everybody knows this, but it's important to have a reminder. The classic classification is into 4 levels: first-degree tears involving the skin, second-degree tears involving the perineal muscles, and then in this cross-section of the anal canal, we begin with a 3A tear that involves less than 50% of the external anal sphincter, a 3B tear, which takes in the majority or all of the external anal sphincter, a 3C tear, which crosses both sphincters, and a 4th-degree tear, which also breaches the rectal mucosa and needs a very careful repair. Not to be forgotten is the buttonhole tear, which breaches the rectal mucosa but doesn't involve the external anal sphincters. So this classification, including the A, B, and C, was devised by Abdul Sultan, but it's been widely adopted, including by the UK's Royal College of Obstetricians and by the International Consultation on Incontinence. There's another classification that we need to be mindful of when we talk about the epidemiology of OASIS, and that's the classification of episiotomy, which was formalized by Vlad Kallis in this publication in BJOG. So the midline or median incision is still widely practiced in the United States, and not surprisingly, a cut that goes from the posterior fourchette directly towards the anal canal is believed to increase the risk of OASIS, and for that reason it can be modified as shown, or a J-shaped incision, to deviate the incision away. What we do in the UK, and I guess most commonly around the world, is the medialateral episiotomy. So that starts at the posterior fourchette and moves away at around 45 degrees. And what I think is done only in Finland is a lateral episiotomy that begins away from the midline and moves even further laterally at 45 degrees. There's some other slightly more unusual episiotomies. Sometimes in the UK we perform anterior episiotomy for women with previous female genital mutilation. So the incidence. I think everyone at this meeting is aware that we don't pick up the majority of our OASISes. Seminal work from Abdul Sultan again for his MD thesis, and he showed that if you systematically examine women with ultrasound after delivery, at least 10% of women have sustained an OASIS, and that's usually undiagnosed. In some populations, it appears to be up to a third of women have some degree of anal sphincter tearing. What's really shocking about it is that we don't need ultrasound to diagnose these injuries. We just need a competent examination using a gloved finger, and that'll detect nearly 100% of these injuries, which is why it's such a shame that we're missing so many. And missing injuries is a big problem for the research literature. It's almost impossible to compare between different studies, because the rates of recognized injury we know vary between different countries. So for example, in this one study across Europe, from less than 1 in 200 in Italy to nearly 1 in 11 in Sweden. But they also vary hugely between hospitals in the same country. So in this example from Norway, 3-fold variation between different nearby hospitals. And that's really acquisition bias, that in different places in the world, people are motivated either to diagnose or not diagnose these injuries. And so it's difficult to compare between different studies. There's another really shocking example of this acquisition bias from Vasanth Andrews when he was working for Abdul Sultan. And he showed that even at the Mayday Hospital, which you'd expect with Abdul Sultan in charge would have a high level of training and a keen focus on OASIS, but even in that setting, the midwives in that hospital were missing a large majority of injuries, and even the doctors were missing around a third of injuries. So we should think about whether the incidence is really changing or whether we're just recognizing injuries differently. If we look at the US, we see that the rates of OASIS appear to be falling sharply, although I think it's now plateaued. There are good reasons why this might be the truth. Doctors in the US have reduced their use of episiotomy, they've reduced their use of forceps, and overall they do more caesarean sections than they used to. So there are good reasons to think that OASIS might have fallen. But also, OASIS is now recognized as an adverse incident, and it may be that doctors are incentivized not to diagnose these injuries in a way that they weren't previously. In contrast, in Sweden, in Finland, and in the UK, we've seen fairly steady rises in the incidence of OASIS. And you might ask, is that just because doctors in the UK are now motivated to diagnose them, are motivated not to miss these injuries, because we know they have serious long-term consequences? I think that was a hard question to answer until quite recently. This data comes from what's called the hospital episode statistics in the England and Wales parts of the UK. It's a little bit detailed graph. The red line shows the rates of first-degree tears right across the whole nation, and they're pretty stable at around 17% of deliveries. In blue, the secondary tears, they've increased quite markedly from 28% to 35% over a 10-year period, and the third-degree tears have tripled over that period from just less than 2% to nearly 6%. So if we believed it was just overdiagnosis, that people were taking second-degree tears and making them into third-degree tears, then you'd see a drop in the second-degree tears, but that's not the case. All the tears are increasing, both second and third degree, which makes it seem like the incidence probably really is increasing. So on to the risk factors. We have almost no evidence from randomized trials about risk factors for OASIS. This one topic, the use of episiotomy, has been extensively studied, and I'll start here. So these are all trials of restrictive use of episiotomy versus routine use of episiotomy, mainly for first-time mothers. And this work was presented by our group at ICS last year as an up-to-date systematic review. Here we've mixed up the medial lateral and midline episiotomy trials. That's a little bit controversial, but statistically makes sense because there's not much heterogeneity. And consistently you see that use of restrictive episiotomy policies, regardless of how you do your episiotomy, is associated with reduced risk of OASIS overall. So that's the limit of the randomized trial evidence. Everything else we're going to talk about today comes from observational studies. And before we talk about observational studies, we need to sound a note of caution about the biases that can be in those studies. And I'm going to give you a true-life example about this man. He was called Abraham Wald, and he was a statistician. And he wrote a seminal paper called A Method of Estimating Plain Vulnerability Based on the Damage of Survivors. Now, obviously, this isn't clinical medicine. It wasn't published in a high-impact factor journal. It was a classified military secret. But it tells us something incredible about observational research. So Abraham Wald's job was during the Second World War to look at the pattern of damage to Lancaster bombers after they returned from bombing runs over mainland Europe. So these bombers were being shot at with flak guns, producing essentially random damage across the plane. I'm going to give you an example and test you out if you could come to the same conclusion that he did. So here's a plane that sustained flak damage after it returns from a bombing run. It's got 6 hits in the wings, and it's got 2 hits in the tail. So I'd like a show of hands for who would add more armor to this plane in the wings. One hand. Who would add more armor to the fuselage? And who would add more armor to the tail? You're a very reticent audience. Should we have one more try? Let's have everyone have a hand up. Who would go for wings? 1. Who would go for fuselage? Come on, panel, lead the way. Couple for fuselage, and who would go for tail? It's a pretty even split. Obviously, 2/3 of you are wrong, and I hope those 2/3 of you find it counterintuitive. The right place to add armor is the fuselage, because if planes were returning from bombing runs, having survived hits to the wings and tail, that's the place where they don't need armor. If no planes come back having survived hits to the fuselage, they need more armor there. So this is a kind of differential loss to follow-up. This is a classic bias for observational studies, and we often ignore these kind of things. We assume that a big observational study must tell us the truth, but actually it can tell us exactly the opposite of the truth if we're not careful. This is another slightly complicated example from one of my papers with Sari Raisinen from BMJ Open last year. So at one time in Finland, the midwives pretty much routinely did a lateral episiotomy for their first-time mothers. That was the trend right across the world, and midwives stuck with that in Finland for a long time. But over the period 2004 to 2011, in line with trends across Europe, they cut back on use of lateral episiotomy. They started to restrict how they did it, even though there wasn't much evidence. If you look in 2004, you can see they were doing it for nearly 60% of the first-time mothers, and that fell sharply across the next 6 or 7 years. And at that time, just like in other countries, the rates of OASIS increased. So in a very simple analysis, you'd think those two things were negatively correlated. But we did something a little bit more sophisticated. We looked at the individual analyses in each time period and saw something really surprising. Back in 2004, when midwives did these episiotomies a lot, it was strongly protective against OASIS, with an odds ratio of 0.73. But as midwives started to cut back on the number of episiotomies they did, they were restricting them to women who were already at high risk of OASIS, women having difficult deliveries of big babies. And so by 2011, it's a strong causal factor for OASIS with an odds ratio of 2.1. So the direction of association has totally changed. Now this is confounding by indication, and there's no way to unpick this kind of confounding in our observational studies. So for all observational evidence, you have to think hard about what biases could have snuck in. Having said that, observational studies paint a very consistent picture for some risk factors. We know that having an instrumented delivery puts you at high risk of OASIS, having your first baby puts you at high risk, and obviously having a big baby puts you at high risk. A long time ago, 6 years ago, I presented this study at ICS, where we tried to see whether we could predict OASIS by measuring the baby's weight antenatally. So we did it with a prospective multi-centre cohort in southeast London, and we recruited women coming to our post-term clinic, so at 40 to 42 weeks gestation, and we did that for two reasons. Firstly, there was a short interval between when we were going to scan them and when they would deliver, and secondly, because these women have well-grown babies, big babies, that put them at high risk of OASIS. And we measured the baby's size using Hadlock's formula, based on the head size, the abdomen, and the length of the legs, and we measured the mother's heights. And then we worked out the Fetomaternal BMI. So that's the baby's estimated weight divided by the maternal height squared, like a normal BMI. So as the baby's weight goes up, the index goes up. As the mother's height goes up, the index comes down. So first of all, how do we do in our scans? Well, this is a Bland-Altman plot, which plots the mean of our estimation of weight and the birth weight against how wrong we were in each scan. Here are 1,700 dots for our 1,700 women. And overall, Hadlock's formula 25 years later works incredibly well even in the post-date setting. So we were 23 grams off on average. That's a great result for Hadlock. And our mean error isn't too bad, around 1/4 kilo, 251 grams, but quite wide limits of agreement. So for 5% of our mothers, we were 600 grams off. That's a pound and a half for the Americans. That's quite a significant error. Having said that, our Fetomaternal BMI was still associated with OASIS. It's quite a big odds ratio, 8 per kilogram per meter squared, but it hardly explains any of the variation in OASIS. It's relatively small compared to just the randomness of OASIS occurring. We're hardly likely ever to be able to predict OASIS, and that's why so much focus is on how we prevent them. One area of interest for many people, including at this conference and at IUGA, is how we should modify our episiotomies. There's reasonably high-quality observational evidence that for women who sustain OASIS, the angle of episiotomy has been cut too narrowly, too close to the midline. And it also seems to be true that women with a short perineum are more likely to get an OASIS. Having said that, in the last year we've seen the first randomized trial of lateral episiotomy versus medial lateral, and it didn't appear to make any difference. There's a surprising amount of evidence about the risk of Asian ethnicity, at least from Western countries. So if you're South Asian or East Asian delivering in a Western country, that puts you at greatly increased risk of OASIS, and we have to wonder why that might be. It could be a big healthcare inequality that we haven't addressed. There's hardly any data from Asia itself, and that doesn't suggest that Asian women are at increased risk in their native countries. This is a wonderful paper from the BJOG last year, particularly of interest to me because I work on genetic factors for pelvic floor disorders. And it shows that there may be genetic factors affecting the incidence of OASIS. So if your mother had an OASIS, when you deliver, you're at approximately twice the risk of sustaining an OASIS after maximal adjustment. But also, maybe more amazingly, if your mother-in-law had an OASIS, you're also at greatly increased risk. So that tells you there must be some factors passing down the maternal genome and some factors coming down the fetal genome, perhaps related to the size of the baby. Of course, there could also be unmeasured confounding. Something that gets overlooked often is the role of a prior caesarean section. It's not that a prior caesarean causes OASIS, but it marks you out as someone who is at risk of OASIS. So in this analysis with Sari Reisnen, we compared women who were having their first vaginal delivery after no previous deliveries and a first vaginal delivery after a previous caesarean section. And you can see that having a caesarean section before puts you at a risk of around 1.5 for having an OASIS. That's even after adjusting for the factors we know about, like the size of the baby and the length of the second stage and how they were delivered. So it tells you there's some unmeasured factors that we don't know about and that they deserve our study related to a difficult delivery, and we need to discover what those are in future. This one also gets no publicity, politically unpopular. It's that smoking is strongly protective against OASIS, particularly if you're due to have a big baby. So it may be that if you are on track for a really big baby, being a smoker helps cut down the size of that baby to a more manageable size. It might be that smoking is doing something to the perineum or something essentially damaging to the tissue that makes you less likely to have a tear. Of course, there are other very good reasons not to smoke during pregnancy. And socioeconomic status. This is a very consistent and counterintuitive finding. Women of higher socioeconomic status, so women who are earning more money or have had more education, are more likely to be diagnosed with an OASIS. I suspect this is mainly related to the diagnosis, that these women achieve better obstetric care, more likely to be examined by a doctor who's more likely to diagnose or treat their injury, so they're more likely to get a diagnosis in this routine database. So in conclusion, OASIS is much more common than we usually expect, and it's getting more common in most places around the world. We know the major risk factors, which are nulliparity, birth weight, and the use of forceps. But in many studies, there are very strong observed effects from socioeconomic status, smoking, having had a prior caesarean section, and age and ethnicity. Very clearly, there are unexplained causal mechanisms that deserve our attention, and our focus at the moment as clinicians needs to be on population-wide measures to prevent OASIS and reduce its incidence. The prediction of OASIS based on what we currently know remains impossible, and many of the risk factors that we have are just not modifiable in any way. I'm very happy to take questions now or at the break.
You have time to take questions if anyone wants to ask. Not yet? Oh, okay.
Anything about the angle?
I'm very uncertain about that.
The use of the midline as it states and lateral or unilateral.
For many people, for many people, that's a real pet topic. People feel strongly about the way they do OASIS. I also have the feeling that when I cut an episiotomy, I like to feel I'm doing good, but the evidence from randomized trials is that I'm not. And it's hard to move beyond that. There's not much to say. You should do less episiotomies regardless of how you choose to do it. There's very limited evidence comparing different episiotomy techniques, and yes, it suggests that medial lateral is safer than midline, but beyond that, we just don't know.
Any other questions? Yeah, well, let's...
Thank you.
Yeah.